My name is Hong Song. I'm one of the nuclear medicine physician faculty in the Department of Radiology. I will be the moderator for this session. And this is an exciting session, oncology, because a lot of the main application of radiopharmaceuticals in this field. I have three distinguished speakers. First, it's my pleasure to introduce Dr. Corinne Burnett. She is a former postdoc of SAM, and she's currently faculty and a professor in MIPS, and she's working on some cool radiopharmaceuticals for cancer targeting. Come on, Corinne.
Okay, thanks, Hong. Can everyone hear me okay? Yeah? Okay, great. So I'm happy to be here today to talk a little bit about my journey as a postdoc and now starting my own lab in molecular imaging and now radionuclide therapy of cancer. So I start here with this photo. I joined Sam's lab as a postdoc in 2015. And I think that this photo was taken about 1 year after my joining. And I just want to highlight, the sheer size and diversity of the lab and just the enormous amount of research that was going on at that time. And this is kind of further exemplified when we look at this diagram of what we think of as the MIPS program. And Sam's lab was really not able to be placed in any one of these boxes. He really spanned the whole pipeline, whether that was looking at new targets, identification of ligand or engineering of binders, radiochemistry and radiopharmaceutical development, clinical translation. He also had a very active program in device development, and all of this was then being fed in to further improve clinical management of disease or answer novel questions about disease biology. So when I joined, I was kind of firmly placed in the middle box. So I was a radiochemist, originally an organic chemist, and I worked on radiochemistry and novel PET tracer development. And I want to talk about my journey through this pipeline and also highlight some quotes from Sam along the way. So the disease area that I worked on was one that was very close to Sam, and it was high-grade glioma. And as we heard this morning, this is a very disease with a very poor survival. It has limited treatment options. It's complicated by the issue of the blood-brain barrier. And we also know that MRI doesn't do a really good job of distinguishing treatment effects from tumor growth, as we also heard this morning. And so we also knew that treatment continued to evolve. So there was always new treatments being developed, novel clinical trials. And so our goal when we started this work was to develop a general metabolic agent that we could employ so that we could know whether someone was going to respond or not respond to any of these classes of therapies very early on. And to do that, we looked at a biomarker known as pyruvate kinase M2 or PKM2. So pyruvate kinase catalyzes the last step in glycolysis. It converts phosphoenol pyruvate to pyruvate. And the isoform expressed in our healthy brain depicted on the left-hand side is PKM1. The isoform expressed in brain tumor cells or other cancer cells depicted on the right is PKM2. And PKM2 is quite unique in that it can exist in different enzymatic states, and this really allows cancer cells to regulate that last step in glycolysis and allow this continual buildup of upstream glycolytic intermediates that can then be funneled into biosynthetic processes and support the continual production of new daughter cells. And so we viewed this as a really attractive target for imaging due to its critical role in glucose metabolism and that it was not expressed in the healthy brain, so giving us a good signal to background. So we developed a small molecule shown down the bottom here known as DASA23, and it's radiolabeled with fluorine 18. So we see here some of the initial preclinical validation we did during my postdoc. So first we see a mouse model of glioma. We see the intracranial glioma present on the MRI on the left, and on the right-hand side, we see a representative DASA23 PET. So we see the clear uptake in the intracranial glioma, the low background signal in the healthy brain tissue. We can also look at the time activity curves and again see the clear distinction between the glioma and normal brain, and this gives a tumor to brain ratio of about 3.5. We also did some ex vivo validation, so ex vivo autoradiography on the bottom left-hand side, which confirmed what we saw in the PET scan. Very nice localization of the radiotracer in the glioma and low background in the normal brain. And we see that this very nicely matches with the pattern shown on the corresponding H&E section. Lastly, we took a look at what types of cells were expressing PKM2 in the tumor microenvironment. And what we saw here is that PKM2 was predominantly and very highly expressed on our glioma cells, shown in purple, with very minimal expression on infiltrating lymphoid and other immune cell populations. So again, providing further support for this target. So Sam then made the decision, and we've heard how much he really pushed along clinical translation. So he made the decision in about 2017 that he wanted to translate this agent very quickly for a first-in-human study. And he really tasked me with putting together the IND application. And so we moved this agent along in the pipeline from the green box further along to first-in-human studies in the orange box. So we submitted our IND in the end of 2017, and in the beginning of 2018, we received our studies may proceed letter, and we opened the study here at Stanford. So this was the first volunteer that we scanned. I remember this day very well. Sam came down to the cyclotron facility, and he watched me do the quality control of this tracer, which I think made me just infinitely more nervous. But then we walked together from the cyclotron facility. We walked the dose up together to the PET-MR upstairs in Lucas, so that's a very nice memory. And this was that first healthy volunteer. So what we see here, we got some initial idea from that first time point that this tracer could passively cross the intact blood-brain barrier in humans, and then it began to clear. We also started to see kind of how this agent was clearing from the body. So we see from these serial scans that it has a combination of both renal and hepatobiliary clearance and some pretty persistent signal in the gallbladder. And as Sam said at the end of this day, you know, the new journey now began. And we moved on to then scanning glioma patients. If you can start my video. So we're going to watch a video moving from the base of the brain to the top of the brain. We're going to see the glioma lesion appear here. So we see the intense uptake of the radiotracer with the lower background in the normal brain. We did see some non-specific background in white matter, but very clear distinction within the glioma lesion. And I have to say that Sam loved these videos. He was very particular about how we made these videos, the way the head rotated, the way that the scan moved and the PET was overlaid. And I think it took about 6 attempts back and forward with me and Fresgy to finally get this video that Sam was happy with. But as I mentioned in the beginning, one of the biggest goals for this work was to know very early on whether someone was going to respond to therapy. And Sam always had the ambitious timeline that he wanted to know within a week if someone was going to respond. And that was a very difficult study to do, but we have one example of that, which I'll talk through here. So we'll begin on the left. We see this pre-therapy MR where we see this very large enhancing lesion in the left frontal lobe. The bulk around the yellow arrow, minimal enhancement down at the red arrow. We then see FDG PET, which this patient had as part of their standard of care. We do see some subtle FDG uptake in the area where the lesion is located, but again, the very high background from glucose metabolism in the normal brain. We then see the DASA23 PET, the clear signal to background and delineation of the lesion as PKM2 is not found in the normal brain. And we also start to see that it's providing additional information than what we see on MR. So we see a lot of uptake down at the red arrow, kind of outside of the bounds of contrast enhancement. And this patient then began their treatment on temozolomide chemotherapy and Avastin, which is an anti-angiogenic agent. And we obtained the post-therapy PET MR simultaneously within 1 week of the treatment. And what we saw in the PET was kind of generally increased uptake throughout this patient's lesion, particularly at the red arrow. So this kind of suggested to us that this was a metabolic non-responder. In contrast, the MR showed an improvement, and this is the classical pseudo-response effect. So we've heard about pseudo-progression, but this is known as pseudo-response, and this is a big confounder when treating people with Avastin. So finally, 3 months out, we see on an additional standard of care MRI that kind of as we thought earlier on, this patient was indeed not responding. They had significant tumor progression, and then they ended up going back to the OR at this point. So I want to pause briefly and talk a little bit about some of the things we learned about PKM2, and then I want to talk about where I decided to go next when I started my own lab. So we developed PKM2 as the first clinically relevant radiopharmaceutical. We moved it along and translated it for a first-in-human study and provided proof of concept that we could detect PKM2 in patients with glioma and detect early treatment failure. So this was a tracer that was born in Sam's lab and translated in Sam's lab and studied at Stanford. So we're happy now. MD Anderson is opening up a study to continue to investigate this agent in patients with glioma, and we've also seen its use as a reporter gene imaging agent, first in Sam's lab, and now a lot of work in Dr. Ferrara's lab. So we then see how these agents can then be kind of put through this pipeline to further clinical management or answer scientific questions about different diseases. And at this point in time, when I was kind of finishing up as a postdoc, I was going to start my own lab, and I really considered that this was my place. Labeling of molecules, validating them, maybe even trying my hand to translate another one. And I think that Sam had the unique ability to continue to challenge people in different ways. And so we had a meeting about 1 year before he passed away, and he said to me, which really surprised me, you cannot just stay in diagnostics. You have to now go back and you have to use your skills as a chemist, and you have to think about developing theranostic agents. And you have to look for receptors that are good for theranostics, and then you have to find peptides, and you have to tweak them, and you have to, again, bring it back to the patient. Initially, you have to study these in diseases where people have exhausted all treatment options. And so this was really surprising to me because I was very comfortable with what I was doing with fluorine-18. And at this point, I want to share a quote from Sam. So this is from his Benedict Casson lecture at SNMMI in 2018. I'm going to read it. He said, "It's been an unplanned journey. I wish I could tell you we knew where we were going. Each year, things lead to the next thing, which leads to the next thing, but the common theme is that we're always venturing to areas that we're not comfortable with. Things that make me uncomfortable tell me I'm on the right track." So I think I'm still too junior to know that I'm on the right track, but I definitely try and remember this quote as I'm going to show you. We're going back into the other side of the pipeline to try and look for targets, try and identify peptides for targets that don't have any lead structures. And that's what I'm going to spend the remainder of the talk today. So when we think about what we need for the development of a novel theranostic agent in this pathway to radiotherapeutics, we need two critical things to come together. One is the biomarker, ideally overexpressed on cancer cells, minimal expression in the normal body. And we also need a ligand, typically a peptide ligand that carries the radionuclide and then induces the cell death that we associate with successful radionuclide therapy. So the first thing we looked for is the target. And we explore a number of targets in the lab, but I'm going to talk briefly about one today, known as B7H3 or CD276. So we see the crystal structure of the extracellular domain shown here below the name of the protein. And the reason we really like this target, and a lot of people also like this target, is that it has this very dense expression across a number of different cancers. So it's often referred to as a pan-cancer target. We also see, this is a graph taken from the Human Protein Atlas, that a lot of patients within a particular cancer type are positive for this marker. And another promising thing is that it has virtually undetectable protein expression in normal tissue. We also know there's a history of this agent in our department and beyond. So we have a program here at Stanford using this for targeted ultrasound of breast cancer. There is a CAR T-cell therapy at our Center for Cell Therapy targeting B7H3. And we also know it's been studied by others for radioimmunotherapy using antibodies. But as we heard, antibodies have this long circulation in blood, so they're not as useful for radionuclide therapy. So one of the challenges was there was no small molecules, there was no peptides, there was nothing for this target. And so where do we go from here? And there's a number of different ways that people approach it, but one way that my lab has approached this is to use peptide phage display. So to do this, we use two different libraries. One is a 7 amino acid linear library. The other one is a 7 amino acid disulfide constrained library. And we incubate these with the extracellular domain of the protein. We pull out those phages that have bound, and then we keep doing this process iteratively until we hopefully see some enrichment. And so initially, kind of in the first round, we see enormous numbers of sequences coming out, no clear trends within any of the peptides. It's very confusing. And then by the second and the third round, we start to really get down to some manageable numbers. So by the third round, we had 10 linear peptides and 12 cyclic peptides. And I will tell you that phage display is like trying to find a needle in a haystack. A lot of these peptides, even at the third round, they don't bind. They likely have growth advantages in bacteria. Anyway, and like Sam said, often would say, you really have to try and find signal in all of the noise. So we synthesized all of these peptides and we tested them experimentally for binding. And I'm going to show a little bit about some of the ones that did bound and how we test these. So we first test these using a technique known as biolayer interferometry. And we see a graph of that shown here. This is linear number 6 peptide because it was the 6th peptide that we sequenced in the linear ones. And so what we look at on the left-hand side, we immobilize the protein on a chip and we dip it into wells of the peptide and we look for their association. So this is the association phase. So we see B7H3 in blue and we see a structurally similar protein, PDL1, which is also known as B7H1 in red. So we see here that there's a clear distinction in the binding of this peptide to B7H3 compared to PDL1. We then look at the dissociation phase. So we look at how quickly these peptides fall off the protein. So we see this linear one really falls off immediately. And then when we apply this peptide and look at a dose-dependent saturation binding assay, we see that it has a KD of over 100 micromolar, so really not going to cut it for a successful radionuclide therapy. Thank you for the nod. And then so we looked at some of our cyclic analogs. So you can see here with these cyclic ones, again, they have good association. They have a better dissociation profile, so they start to hang on to the protein a little bit longer. The problem with these ones is that they also started to show binding to PDL1, so we were losing the specificity. So we moved on, and we came to this peptide, C12. And so what we see here is a very nice association curve, a very slow off rate of this peptide, so hanging onto the protein much longer, which is exactly what we want, and really a flat line when it comes to PDL1. And so then we were very happy when we look at the saturation binding assay, we start to get down to a KD that we can work with. So we have a KD for this peptide of 32 nanomolar. So we still have to improve it, ideally into the single-digit nanomolar range, but this is really something that we can work with. And we're really happy because for a target where there was really nothing before, now we have a lead structure that we can start to modify. And so I'm going to kind of wrap up this part of the talk and tell you that hopefully I've shown B7H3 is a very promising target for radionuclide therapy. We've learned that we can apply phage display to identify lead structures where one does not previously exist, and we've done this for a number of other targets in the lab. We typically find that the cyclic peptides, although they're kind of not the chemist's favorite, they are much better at giving affinity initially. And so we're kind of developing this program in ligand identification and optimization. And we're currently using C12 as the lead scaffold, so the 32 nanomolar binder, to fine-tune its affinity and introduce a metal chelator for diagnostic and therapeutic radioisotopes. So hopefully we can then continue to move this along and develop a radiopharmaceutical and potentially even go back to a first-in-human study. So I want to thank, this is my lab. So on the family tree, these would be Sam's newest grandchildren because I'm the most junior faculty member here at MIPS. And we have some new members that were not present when we took this photo, so we need an updated photo. So I want to thank my lab, thank all of our collaborators, all of the facilities, the funding sources. And I first want to thank and acknowledge our wonderful late director of cyclotron and radiochemistry. And I showed down the bottom here another quote from Sam from the end of his 2018 lecture at SNMMI about the importance of the journey and treating everyone with respect. And I think that Bin is the best example of this quote. He really enjoyed his journey and he treated everyone with respect and meticulously designed every centimeter or every inch of our new facility that has led to Sam's vision becoming a reality. So lastly, I'd like to thank and honor my wonderful mentor, Dr. Gambir. You know, I received so much inspiration in my postdoc, and I think that's one of the main reasons I can continue down this scientific journey. And so it's really an honor to speak here today at this symposium honoring Sam and his family, and happy to answer any questions.
Yes, thank you, Corinne, for a really inspirational, very interesting talk. Thank you very much. And this talk is now open to questions. Yes.
How does the prior treatment affect this protein on the surface of the tumor cells?
I don't think that's known so much yet. So
I think that may be important because you're not usually going to be dealing with untreated patients. You're going to be dealing with recurrent patients. So you may want to get some samples and test to make sure that the protein is still unmodified and still where it should be.
Thank you.
All right, thank you. Thank you again, Corinne. Okay, next, it's my privilege to introduce Dr. Andre Iagaru. Dr. Iagaru is the Division Chief of Nuclear Medicine and Molecular Imaging and Professor of Radiology at Stanford. Thank you.
Thank you, Hong. It's really, as everyone has said, it's a privilege to be here in front of you. I'm going to talk, as soon as the slides are up, a little bit about Sam, a little bit about the history of Stanford and nuclear medicine at Stanford. I'll show a brief video from when we opened our clinic in 2010, and I'll set everything in perspective based on some of Sam's words there. So I'll show you what we tried to do over the past decade plus to keep Sam's vision alive, and then I'll share with you our vision for the future. So perhaps many of you know that the School of Medicine was actually in San Francisco until 1959. And these buildings that you can see from these windows to my left and your right were part of the plans in 1959. And then this is how it looks today. So you can see how much has changed over 6 decades plus here in Palo Alto. So I think it's a remarkable growth. And I'm happy to say that our field has been a great part of this growth. And we're present in nuclear medicine throughout all the aspects of the Stanford healthcare enterprise. We are everywhere where Stanford is. Again, very proud of that. We also recently celebrated 75 years of nuclear medicine at Stanford. It's a great history, and it started with Professor Newell, who stepped down as chair of radiology to start this new discipline. And it's unique, I think, in that nuclear medicine, radiology, and radiation oncology were one department, I believe, until the 80s. So there's a lot of corporate memory where we get along well with each other and we work well with each other, and that's not always the case. And each of these individuals were unique and fantastic in their own ways. And in this building, there's still art that was produced by Professor Joe Chris. He was one of the first to create computer-generated art, and you can find his work on the first floor here. And needless to say how much Sam meant for molecular imaging here. There was nuclear medicine here, but molecular imaging really started when Sam joined in 2003. It used to be that all our patients who needed PET used to go to George Siegel's clinic at the VA, who himself is a pioneer of PET. There was no PET here until 2005, a couple of years after Sam came. So it will be awkward, but let's listen to this video, please.
Thank you very much. So to end, before we do the ribbon cutting ceremony, I just want to give you some closing remarks. As I said, you know, the most important thing in life is your health. That's why a lot of us are in the healthcare business, but we want to be in a field where we make a difference in people's lives. All of us have had family members and friends affected by some aspect of disease, and really that's the reason we're all gathered here. I will guarantee you that the walls in this clinic will fundamentally change how people are treated over the years. We all share in a common vision, and all the students that are here, the postdocs, the scientists that help build the next generation of technologies are determined to bring things to this clinic that will fundamentally change how we manage patients' lives. Eventually, these spies that we talk about that go into your body will be replaced by spies that maybe live with you for years, spies that are not radioactive. Eventually, they'll be linked to blood testing that will be done routinely, and maybe even urine testing that will detect disease very early. We will really push the field of diagnostics imaging very carefully forward. We will do so very cost effectively. We're determined not to just do imaging for the sake of imaging. It has to be used in a very cost-effective way. You don't want to order tests that are not a good use of medical resources, and you want to develop the next generation of tests that are cheaper, that can be deployed outside these walls and make an impact throughout the world. And all of the scientists and physicians here are committed to that. We've also designed this clinic to do new clinical trials. Just this coming week, a new kind of spy will go into a patient for the first time. This spy is designed to find newly growing blood vessels that are being formed in tumor sites based on a receptor present on those new blood vessels. New spies that hunt for Alzheimer's disease will be put into patients for the first time. Many first trials will be done in these walls, then will disseminate through our community and hopefully throughout the world in order to improve healthcare. Stanford will lead the way to do this, and nuclear medicine, molecular imaging will help lead the way for the field of medicine to help do this. So in summary, remember, if nothing else, that nothing is more important than human health. The technologies that we will develop and will use that exist now will fundamentally change how we improve management of healthcare and, more importantly, earlier detection of disease. To quote a great physician from the past, all who have accomplished great things have had a great aim, have fixed their gaze on a goal which was high, one which sometimes seemed impossible. So although now people would say it's crazy for us to be thinking that we could detect tumors that are less than a millimeter in size, we are committed to that goal and aim, and we will succeed in that aim. And finally, there is no medicine like hope, no incentive so great, and no tonic so powerful as expectations of something better than tomorrow. We are all committed to building a better tomorrow. Please join me in opening this brand new clinic. Thank you very much.
So this was October 2010, and I think it rings as accurate now as it rang then. Obviously, it can tell you what kind of pressure all of us who continued Sam's excellent work have felt throughout the time. So let me show you briefly some of the accomplishment over the past decade plus. So let's start with bench to bedside. You heard him talk about a new agent looking at new blood vessel formation, angiogenesis. So we focused on the integrin alpha V beta 3. Many people at the time were doing the same thing. Sean Chen here, Sam and others developed this. Siemens GE were working on their own molecules. We shown that in preclinical models, this was better than the standard galacto-RGD. We published multiple papers. I'll show you a few images as an example. Here are patients with breast cancer. So the patient on the left, the primary breast lesion, there's uptake, so there's angiogenesis there. It makes sense to treat these patients with a drug against angiogenesis. There are also a lymph node in the axilla, very small, and a thoracic spine metastasis, very small. FDG did not find them. In contrast, the patient on the right, very little angiogenesis signal in the breast, although the bone lesions had angiogenesis. So why should you treat this patient with an anti-angiogenic drug alone? So we felt we had a slam dunk agent here ready to go to pharma, say, hey, we'll help you select patients for anti-angiogenesis medication. As Corinne said, Sam always wanted, and this is sad and ironic, we were working on this before Milan was diagnosed with GBM. These are two patients with GBM, and the patient on the left Angiogenesis before Avastin at 1 week, signal did not change. Typical story, this patient progressed. This other patient, angiogenesis before Avastin, at 1 week the signal is gone. This is just wound repair where the surgery took place. At the 8 weeks mark, standard of care, there's no more signal. So we've proven in this publication that as early as 1 week, you can separate who's going to respond to Avastin, who's not. This patient actually happened to have lived for 30 plus months, so outstanding story. But the pharma did not want a smaller market, better selection. They wanted to have a blockbuster drug for a longer period of time. We also shown that this works in metastatic renal cell cancer, in patients with cervical and ovarian cancer. And Sam also taught us that, sometimes it's called research because you're not successful on the first attempt. So we gave up on that. But now I'm happy to say that Novartis, one of our partners here, is starting a study with a similar compound, a theranostics agent, looking at angiogenesis as well. So perhaps this is not completely done. I'm going to focus most of this part of our research on bombacin, on gastrin-releasing peptide receptors. This is also something that we studied from bench to bedside. GRPR is very important in many aspects of the biology of cancer and other biological processes. Again, this RM2 molecule has been proven to work in preclinical models, including therapy versions, lutetium. You can also label it with an alpha emitter as well. Also, rapamycin, a radiosensitizer, makes it even more efficient in these preclinical models. It has a very different biodistribution than PSMA, and as good as PSMA is, at best, it finds lesions in 90% of the patients, but not 90% of all lesions in every patient. So it leaves a large population of unmet need for prostate cancer. And we've been able, through funding from various agencies and industry sponsors, to show that this works in all instances, from biopsy guidance of men with high PSA but negative or equivocal MRI, to pre-surgery, to tell urologists what they need to do surgery. And this is an example, pathology showing that the lesion, the signal on PET, correlates very nicely with the tumor. Also in this example, while both PSMA and bombacin found the primary, this lymph node, I think it's much more conspicuous on bombacin than it is on PSMA. And of course, I'm showing you the best examples. There are many other cases where PSMA works better. A tumor positive on bombacin and negative on PSMA. Our largest experience to date is this biochemical recurrence, where we're lucky to be able to take this molecule from a phase 1 to a phase 2 to now a completed phase 3 study. And the phase 3 study was funded by the Department of Defense through an impact award. The first pilot study compared PSMA and bombacin in 7 patients. The first patient ever injected with both in 2015 had more lesions on bombacin than on PSMA. So that really motivated us to continue. And this is work that happened over a decade. We've also shown that the PSA velocity is a marker of bombacin positivity. So patients with negative bombacin had lower PSA velocity, so perhaps less aggressive tumors. Perhaps a false positive bombacin is not too bad. We know that we overtreat some of these prostate cancer patients. And Sam always told us, and I think those of us who work with him remember, don't just publish in your field. Publish where it matters. Publish in a high impact factor. And just a couple of weeks ago, this was accepted in Lancet Oncology, the results of the phase 3 study, showing that actually if you look at PSA quartiles, the positivity rate for bombacin, it's on par with the positivity rate of PSMA. So we just need to find out which patients will benefit from this in addition to PSMA. And this is a graph of the same results. So how does it compare with PSMA? You find some lesions with both. You find some lesions with one and not the other, and vice versa. So I would argue, even in patients where you see the same lesions, why not alternate cycles, right? You may reduce toxicity from each radiopharmaceutical while maintaining or maybe even improving the efficacy of these radioligands. And this has been tried in humans. The beauty about it, you may have been concerned about the high activity in the pancreas. Well, this washes out from the pancreas by 24 hours, and then it stays in metastatic lesions, in this case, up to 168 hours. And other groups have proven the same thing. Happy to say that there's more molecules around this class. There's second generation as well. Probably one of the best ones. Thomas is here in the room if you want to talk to him more about it. We're very excited about this gallium AMTG. It can be labeled with other isotopes for therapy purposes as well. So we're really looking forward to more results from this, and so is the industry. There are at least these companies that are interested in the GRPR space, And I really think that this is one of the next frontiers in radioligand therapies. I'll tell you a little bit more about clinical nuclear medicine, how we did in this decade plus. Happy to say that nuclear medicine is growing as fast as all the other aspects of radiology. So both PET and general nuclear medicine, a lot of growth. These are our total number of visits, and I think that if this was a business, everyone would be very happy to see this kind of inverted cross figure. So a lot of growth, a lot of demand for what we offer, which means that nuclear medicine provides good answers to our clinicians. The clinicians would not order a test if it would not give their patients a good answer. I'm also happy to say that the pediatric nuclear medicine at Stanford under Dr. Helen Nadel's guidance has grown significantly, and the pediatric PET/MR program, and these numbers have to be updated, it's more recent ones, it's probably the largest, not in the US, but in the world. We do more pediatric PET/MR here than in a lot of many other places. And part of her presidency of SNMI, she focused on pediatric radioligand therapy, theranostics. So I hope that she will be successful in bringing theranostics to peds as well. How do we build on this? Our philosophy here is that to have success, you need a lot of this. And the most important is people, and I'll come to that in a moment. Talking about space. The clinic, some of you visited. If you did not, please reach out. We'll be happy to show it to you. This clinic took more than 7 years to open, from when Sam came to when it opened in 2010. It was an outpatient surgery center before, and until they vacated all the ORs, construction could not start. But we knew in 2010 that it's like a living organism. You need to keep updating it. You need to keep bringing new technology to stay top of state of the art. So this is one of the memorable moments, the Theranostics Clinic opening. David shown some of the pictures from 2021. We started planning for this in 2014, so it took a long time to get it done. But through the work of my colleagues, Karina, Erin, everyone else who works there, this received the first accreditation in the country from SNMI, the first designation, and last year the first accreditation for an academic center by the IAC. So clearly the team is doing a great job. Industry prediction on the left, how much therapies will grow, our actual numbers on the right. So we're matching the industry predictions, and this is despite a fiasco last year with production of one of the radiopharmaceuticals that was not available in the country. So this curve would have been even steeper if we had access to more. And our colleagues in medical oncology are telling us that the volumes for Pluvicto alone will triple or quadruple as we move to earlier stages of disease. And we'll be ready. Oops, sorry, maybe someone can help me here. All right, I got it. Through investment from SAC and our partners on the hospital side, you've seen perhaps that there's some renovation going on in the old D, E, and F pods. Those are going to be turned into a cancer hospital. We'll have lead line rooms there. We'll have 3 lead line rooms. So if a patient will need to be admitted, they will be admitted in these lead light rooms, including up to high activity iodine-31. A lot of people were included into these activities. And these are oncology wards. So when not in use for us, they will be used by medical oncology. This is from the construction. And this is how this room looks now. This opened a few months back. It's a beautiful space. It's on par with a new hospital. And we'll start admitting patients there once the other pods will be renovated, so everyone will have place to move. Equipment, it's equally critical. First PET/MR in the world, first digital PET-CT in the world, as well as multiple investments in new SPECT-CT throughout our entire enterprise. So again, many thanks to our partners at SAC for always being together with us ahead of time. This new technology allows us to do new things. SPECT was always criticized for being slow. Well, we've shown that actually you can do SPECT at the speed of PET. This is really remarkable, and our workflow for these patients include imaging after each cycle, because it's a simple thing. It's 8 minutes or less of imaging for SPECT-CT. That sometimes is faster than you can do PET with standard field of view. And so this is just an example of patients through the journey of Pluvicto treatment from beginning to when a great response is observed after 6 cycles. This work that my colleague Hong Song is doing, showing that these scans are not just pretty images, they're actually able to predict the outcome of treatment. So the tumor of PSMA expressing, the volume of tumor expressing PSMA correlates very nicely with the PSA response. This also shows us that you don't know what you don't know. So these patients with neuroendocrine tumor on FDG, 2 lesions, on diagnostic dotatate 2 lesions. Post-treatment, only 1 lit up. So do you expect this patient will have a complete response? The treatment did not go there. If we didn't scan, we didn't know. But this opens up the door for new technology. Perhaps this patient can be then treated with external radiation with this new technology that Dr. Lee will talk to us next about PET-guided radiation therapy. But again, if you don't scan, if you don't look, you're not going to know what's going to happen. As I said, we try to constantly stay current and up to date. This is our layout with equipment. This space, the satellite radiochemistry, took a lot of effort to build. And it was critical for us to introduce radiopharmaceuticals before FDA approval. We did gallium dotatate before FDA approval, gallium PSMA-11 before approval. But now it's obsolete, and it's too expensive to renovate it for clinical use when we have the second radiochemistry facility. So we're planning for extended field of view PET, again, with our industry partners, as well as for additional modern spec CT, as well as for additional therapy rooms. We don't stop planning for the future, because if you stop, you lose out. We're also going where the patients are. So we don't want patients to have to travel to Palo Alto for a simple PET CT that can be done elsewhere. And I see Elizabeth smiling, and I'm happy to see her smile. So we bring these technologies where the patients are. And again, this is a great testimony to the efforts from SAC. Collaborations are critical, and this is just in the space of prostate cancer. These are our colleagues in radiation oncology, medical oncology, and urology. We cannot do this work without them. This is a team sport. You cannot do theranostics or any of this alone, and we're very happy to work together here. We also give back, and this is another way of engaging the community. The patients who had these scans done here before FDA approval did not pay anything out of pocket. We covered the cost of the radiopharmaceutical. The hospital waived the cost, the technical fee for the use of the scanner, and the physicians read these scans without billing. So we gave back to the community as part of this success. We're also partnering with the CRF and MIPS. These are the 2 facilities. You'll see the one on the right in the afternoon. And I'll come to the most important part, which is the people. You need visionaries. Gary Glazer was a visionary to be able to recruit Sam here. And you heard how many times yesterday and today what a visionary Sam was. And you need supporters. And I want to thank Gary and David for supporting us. And everybody who does the work, these are just the technologists in nuclear medicine. Our team has grown significantly. None of this could be done without them, nor without the future of nuclear medicine, our residency program that started in 1973. These are our current trainees, and we look forward to training many more generations of nuclear medicine and radiology experts. And these are our faculty now, and we continue hiring. So if you know of good people who want to join, please let them know. How about future directions? I know I'm at the limit here, so I apologize, but I want to mention this as well. The future will include these novel radiopharmaceuticals. We will for sure include them in clinical translational research, and these are just some of the radiopharmaceuticals for which we hold INDs and are produced at Stanford. And I'm using the same slide as Corinne did, because I believe in it. This is truly a model that reflects what happens here in MIPS and then in nuclear medicine. And I do think that we need a new paradigm for cancer patient care, and I do think that we'll partner with our colleagues in radiation oncology, medical oncology, and we will bring these technologies not just here, but Cancer Center South Bay, the future Stanford Sutter Cancer Center, and the future cancer campus at the VA. And from there, they can go to multiple other places. These are not built just for us. These are built for the worldwide use. Now, let me be a little bit controversial. You heard from Marty about this conversation between Johannes and Sam. Sam supported theranostics, but he supported it as a short-term solution, as a short-term win. Our victories will not come from therapies. They will come from early disease detection. We continue to focus on the wrong end of the problem. And we shouldn't celebrate how full our hospitals are. We should celebrate when our hospitals are empty. So let me end with a few thoughts here. It costs way too much to treat patients with stage 4. You can't even comprehend the level of difference between early cancer detection and late stage cancer. I mean, of course, we need to continue offering treatment for these patients who are at the end of their journey. But I'm convinced that we'll do better if we find this earlier. And Sam laid out this vision of precision health, not precision medicine, precision health. And this was adopted at the university level, at the School of Medicine, Stanford is looking at precision health. And I do think that these radiopharmaceuticals that we develop here at MIPS and our partners in the industry are developing, together with very sensitive scanners, like again our partners are producing, will allow us to do cancer screening in high-risk population. And I do think that that will move the needle. And of course, these are from Sam's papers showing all the wearables that will help us identify changes in health early. And his favorite analogy that if we can monitor an airplane engine and tell the crew on the ground when to change the oil and all of that, it's something incomprehensible that we cannot monitor human health. And that was the baseline study, which took many healthy people and monitored them until developed disease. These are nuclear medicine babies. I really hope and think that when they grow up, cancer will not be as big a problem as it is for our generation. So I want to end by thanking all our team in nuclear medicine. There are more than 90 people working in nuclear medicine now. And I'll come back to a picture. I know that Dave had it yesterday as well, the retreat. Sam woke up every day at that retreat early and cooked breakfast for us. So I don't know how many people can say that about their boss. He was just amazing. And then those in-depth conversations with him are priceless. So always missing out those what-ifs and challenging you to the next level. And I miss Sam and Aruna and Milan as well. The picture in the middle is when they visited Romania, and I was so nervous because I'm from there and I wanted that trip to go great. And you go to Eastern Europe, sometimes things don't go well. And they didn't want any help. I offered, hey, I have a cousin who will be happy to take you there. They're like, no, we'll rent a car. I'm like, oh, I don't know if that's the best idea. So I was very stressed, but they loved it there. And in fact, at their house, they had some paintings from that trip. And with that, I apologize for going over time. We probably don't have time for questions. I'll be happy to take questions after this session, and thank you.
So next, it's my privilege to introduce Dr. Quinger Lay. And Dr. Lay is the Catherine Dexter McCormick, Stanley McCormick Memorial Professor and Chair of Radiation Oncology and Stanford. And Dr. Lay will share with us her thoughts and experience with the reflexion technology. Thank you.
Good afternoon. These are my disclosures. Just want to mention that we do receive research grants from Reflection, which is the topic of this talk. I just want to take a minute to acknowledge Sam and Aruna. This is a photo collage of Sam with pictures of Sam and his trainees, as well as many of the colleagues here at Stanford. It was put together by Ted Grave when Sam was sick, and it's really reflect all the impacts that Sam had had in many of us here at Stanford. I don't know if you know, but Sam was appointed chair of radiology a few months before I became chair of radiation oncology. So during the first year as chair, I spent a lot of time knocking on Sam's door, asking for help for negotiation, asking for advices, how to be, manage faculty member. And with Sam's help and guidance, I was able to navigate some probably the most challenging situations as a new chair. I'm forever grateful to Sam. I also know Aruna through Cellsite. I'm a head and neck radiation oncologist, and we were trying to bring T-cell imaging for predicting immunotherapy in patients with head and neck cancer. Unfortunately, with Aruna's passing, much of that has gone, but I'm hoping that some of you in the room will continue her passion and her legacy to bring this to the clinic, because we really need to figure out who we need to give immunotherapy to. As a clinical chair, some of my favorite moments are actually hanging out with other clinical chairs, strategizing and socializing. And here's a picture of one of such moments where we all don on hard hats to go visit the new hospital before it was opened. As you can see, Sam was smack in the middle of the group. You heard recently from Andre that Sam really advocates for precision health. And one of the common things that Sam said that stuck in my mind forever is invented at Stanford, used everywhere. And I'd like to take the next few minutes to show you an invention that actually came out from one of Sam's postdocs when he was at Sam's lab. As a department, we helped to move it forward into clinical care, as with the goal to improve cancer patient survival everywhere. But since most of you are not radiation oncologists, I'd like to give you a little bit of a journey of what radiation oncology is about in the last 50 years. Since the first invention of linear accelerator here at Stanford, for 20 years or so, we deliver radiation to these lead block cut fuel. We can't use lead anymore, but that's what we do for a long time. Within the next 30 years or so, there's a lot of invention that take to where we are today, with incorporation of computerized treatment planning. These multi-leaf linear accelerators that move in real time and allow us to shape the beams and pin the dose. Incorporation of onboard imaging with MR scanner or CT scanner. So here we now, in 2024, deliver standard of care intensity modulated radiotherapy, or IMRT for short, and image-guided radiotherapy, or IGRT for short. What we hope to do is to incorporate PET imaging into this treatment with this new machine called reflection, and move forward to the next generation, which is biology-guided radiotherapy. So Stanford's always been in the forefront of many of these inventions. As I mentioned to you, in the 50s, when we moved here, we developed the first linear accelerator under the leadership of Dr. Henry Kaplan and Edward Clinton. This is LA1. In the 90s, we worked together with Dr. John Adler Neurosurgery to develop the CyberKnife machine. And recently, we worked with Sam Mason to move forward into the clinic with Reflection 1. At the same time, we worked together with SLAC to develop this new phaser machine that hopefully can deliver radiation in less than a second. And we've had many other inventions, including this cool name Avatar, which is a very simple development that allows us to treat pediatric patients without general anesthesia. So I'd like to outline my talk by talking a little bit about clinical need of ablative radiotherapy, the definition of biology-guided radiotherapy, or also known as PET-guided radiotherapy, or Syntex, or BGRT. When I say one of these, they're identical. Talk a little bit about clinical experience with this BGRT and the future direction. So why do we need to expand the role of radiation? Because with systemic development of better therapy, systemic therapy for patients with metastatic disease, including immunotherapy and cell therapy, many of these patients are living longer. And so there's an increased important role of local therapy to these patients. As shown here in these two trials, one of them focused on patients what we call oligometastatic disease, patients who present with 5 or less lesions at the beginning. The standard treatment for these patients is with systemic therapy. And when patients are randomized to systemic therapy versus the same treatment plus the addition of ablative radiation, you can see there was a substantial improvement in progression-free and overall survival for these patients. Patients who present with more than 5 lesions, then they started with systemic therapy. Many of these lesions will shrink, but many of them continue to progress or grow. And these are called oligoprogressor. If they have 5 lesions or less, they continue to progress or grow. And so this CURB trial takes these patients who actually have oligoprogressive disease, randomize them to a new line of systemic therapy or versus a new line of systemic therapy plus local radiation ablation. As you can see, these are patients with breast and lung cancer. There was a substantial improvement in progression-free survival in these patients, especially in patients with lung cancer. So why is it hard to treat these patients? Because these lesions can present anywhere in the body. They can be in the lungs, they can be in the liver, they can be in the bone, and they can move very differently. And so we have to track motion of the organ that's they're in, but also the location where they're in, the tumor motion. We need to real-time image these lesions in order to focus the radiation toward the lesion to minimize toxicity. And the pie in the sky is actually you want to treat all these lesions at the same time rather than bring them back 5 different times or 5 different settings to treat these patients. So currently, and I'm not sure whether this is going to happen or not, I'm going to try to move this. Currently what we do is we put fiducial into these tumors, and we track them by fluoroscopy. So in this lung lesions here, you can actually see the lesion pretty well in fluoroscopy. You see the 4 little dots, so the gold fiducial where we track them. When the tumor move into the green box, the radiation machine is fired on to track that. In the next, and I'm hoping this is going to work for the next one, which is right, oops, can you go back and can you play the video for the next? There you go. You can see the video right there and just hit click play. So this is a pancreatic lesion. And you don't think pancreatic tumor move, but they do. So that's a stent in the pancreatic tumor, and you cannot see them through fluoroscopy. So we have to track the stent inside the tumor. So the question is actually, can we use a different approach to image the tumor in real time and track and use that signal to track the tumor? And so that was a concept that was thought up by Sam Mason, who's shown here next to Sam Gambier. And I don't have a pointer, but he's in pink. And when he was a postdoc here at Stanford. And so he developed this concept of BGRT and moved forward to develop this new reflection machine. But the concept is that we can use it's a novel radiation modality that uses a PET signal from injected radiotracer to visualize and track treated tumor in real time. The radiotracer is actually a biologic fiducial. It has unique dosimetry and workflow. And through the work from us and UT Southwestern, it's now FDA approved for FTG use, and additional tracers on the way. So here's a picture of reflection that was installed here at Stanford, the very first in the world. It has a linear accelerator component with a magnetron energy source of 6 MV. It has a multi-leaf collimator that moves very quick, so we can shape the beams as we want to along the way. It has a true diagnostic CT on board, so we can image the tumor with a CT. It has PET detectors, so we can detect the signal from the PET tracers and image the tumor. Everything is mounted in this circular gantry that's enclosed, so we can move the gantry very quickly, 60 times faster than your standard regular gantry by regulatory purposes. And it has a lot of more, whistles and bells I don't know and can't remember, but allow us to be able to actually calculate the dose of the tumor, detect the dose, and also recalculate at the end. So here's an example of the planning CT in the middle, which is a diagnostic CT. You can see the reflection CT on the, I'm not sure the right or the left, but my left here. And then the cone beam CT of the standard linear accelerator, and you can see the reflection CT is much of diagnostic quality. I don't pretend to understand how BGRTs deliver. I leave it to the physicists. My understanding is that they take these different PET projection. They figure out how to do the firing filter, calculate the dose, and deliver the dose in slices that match the PET CT. And so you have a 3D reconstruction of the dose there. As a physician, what I do is, we outline the tumor, what we call the GTV of the gross tumor target. We put a margin around it, about 5 millimeters for daily reproducibility. We can actually see the tumor moving in the PET, which is the motion extend in the dashed black line there. And then we create what we call a BZT, a biologic target zone around it. So when the tumor moves into that zone, then the machine is firing and give the radiation. So here's an example of what we can see on the linear accelerator with the PET LINAC. And you can see the red is a BZT. So in order to move this forward to get FDA approval, Stanford and UC Southwestern worked together to conduct 2 small studies. The first study the FDA asked is what FDG dose do you need in order to be able to detect and track? So we look at the first dose was 15, and I'll show you the data, but that was the only, we were able to just deliver that dose. We didn't have to escalate the dose of these patients. So that's 15 millicurie, and so that's the first cohort of 6. The second cohort of 9 is to confirm that the emulated dose distribution is consistent with the approved plan MD dose that's shown on the dose volume histogram there in green with the bounded volume histogram. So we enroll 9 patients onto the study, bone or lung tumors, with the tumor has to be between 2 to 5 cm. SUV max has to be 6 or greater, and it has to be away from FDG avid structures such as the heart, the kidneys, or the bladder. And the outcome of this study is really that the dose that we emulated delivery, so this is not actually delivered on the patient, but in silico, that whether we can actually deliver the dose and whether it would fit within the 95% of the bounded DVH that is shown and acceptable and approved by the physicians. So the first cohorts I mentioned, we enrolled 6 patients. We showed that 15 millicurie was enough to be able to visualize and track all these tumors. So we move forward to the second cohort, which is a patient with 4 lung metastases and 5 bone metastases. We have 17 amyloid delivery because some of these are actually multiple treatments, 2 to 3 treatments per patient, given every 2 to 3 days apart. So 16 out of the 17 amyloid delivery resulted in synthetic dose distribution, which is acceptable within 95% dose agreement within the approved bounded DVH. We show that all the amyloid dose deliveries is physically deliverable. And when we give these patients, some of them up to 3 doses of FDG or 4 doses of FDG every 2 to 3 days, there was no toxicity attributed to multiple FDG injection. So here's pictures of some of the data, the patients that we have, a lung lesion and bone lesion that was submitted with this FDA package. And here's the absolute data. So if you look at the activity concentration within the tumor, for imaging, first fraction and last fraction, they're very similar to each other. Really, the goal is really the last fraction does not, as we continue to treat the tumor, these patients that we don't want the activity to go below where we can detect. And here's the normalized target signal within the BTZ, again, very similar in terms of imaging first and last fraction. So based on this, FDA approved for bone and lung tumors to be treated for FDG PET using the same inclusion and exclusion criteria to guide the treatment. So far, since FDA approval, we've treated 2 patients at Stanford, and I think there's a few more across the country. We were able to evaluate post-treatment doses, and now we're activating a registry trial with quality of life and clinical endpoints. Here's an example of the very first patient treated with BGRT here and anywhere. She's a 58-year-old lady who had 2 lung metastases from colorectal cancer. It was treated with standard ablative radiation with CT guidance in 2021. Unfortunately, one of the lesions in the right upper lobe recurred in 2023. It grew to about 2.5 centimeters in size, and so we enrolled her as the first patient of this BGRT trial. So we have, we performed the 4-dimensional CT scan of her imagings. We outlined the gross target volume in the thicker red in there. We create what we call planning target volume in the lighter red around. And then the BTZ zone, where if the tumor moved, if the PET tumor moved within that blue zone, then the machine will turn on and give radiation. So the patient was scheduled to receive 4 treatments of radiation every other day. Each of the dose is about 15 grade. And so here's the fraction 1, and as you can see, the planned dose to the delivered dose that we're able to calculate it was very similar to the both planning target volume as well as the gross target volume. And the lines over here, the dash and the thick line, one of them is delivered dose and one of them is planned dose, and you can see they're very much identical to each other. For the 4 treatments, on the left is what we call BGRT plan, and on the right is BGRT delivered dose, 60 grade. And you can see the dosimetry is very similar. And the dose volume histogram, and I'm going to try to see if I can point the pointer on this. I don't think I can. But the dose volume histogram are very similar. The triangle ones are the one that's delivered, and the square one is the one that we plan. So you actually receive a little bit more dose to the tumors and very similar dose to the normal tissue. So the question is, where are we going from here? This is approved for FDG PET. We have many other, as you heard from Andre, many other tracers are either in clinic or moving forward. And that's where I'm more excited about, is whether we can actually look in developing BGRT treatment to novel tracer as well. And one of such is PSMA. And so here's a trial that's going to come out with City of Hope and us start looking at that. But what they're doing is they have actually showed that they can use BGRT to track and do in silico delivering or of this PSMA lesion bone metastasis. So we showed that we can actually be able to see, visualize, and track bone metastasis using a PSMA tracer. So hopefully we can activate this trial soon. But you know, PSMA has been into the clinic as a novel radiopharmaceutical. And I've told you about the oligoprogressor. Not every patient with PSMA radiopharmaceutical treatment, Pluvecto treatment, is going to respond completely. So if you have these oligoprogressor, we can actually target with external beam and hopefully prolong their survival. So the vision is really to move to use this approach to improve the therapeutic ratio, reduce margin and treatment toxicity, more focus to the tumor. It has a unique dosimetry and also the unique imaging. So we actually can play around and give more dose within the same tumor, more dose to the hotter part of the tumor and less dose to the colder part of the tumor. We can do all that as well. We can look at novel tracers. We would like to increase indication of SBRT. Right now it's only approved for bone and lung, and would love to be able to expand to treat soft tissue mets, especially those in the liver, adrenal glands, or lymph nodes. We'd like to enhance precision of dosimetry for BGRT plan. And we want, the pie in the sky for me is actually to treat tumors at the same time. I like to take the patient back with 5 mets and be able to give one treatment in one time, or maybe 2 or 3 treatments at one time, treating all the mets at the same time. So this takes a village to move forward. We installed this machine during the pandemic, and I'd like to thank all the Stanford team in both radiation oncology and radiology who helped us with this, including the physician, physicist, RTT. I'd like to especially acknowledge Murat Suruku and Lucas Vitham, who actually do the work and give me the slides to present to you. I'd like to thank the Reflection team to allow, who really have been partnering with us from the beginning, and especially Sam Mason, the founder of the team. Thank you.
Thank you very much, Dr. Lei, for a very comprehensive review of BGRT and the refraction technology. This talk is open for questions.
It must be very clear.
Okay, over there. Yeah.
Thanks, man. That's a great talk. I was wondering if you, thanks. If you have any ideas with BGRT, how to take SUV traditionally from FDG and something like, I guess, EGFR or something in head and neck, that'd be interesting. How do you do the correlation of SUV, do you think? Do you think it'd be, you said you don't know how they target, but would it be a relative 1-to-1, or what are the thoughts there?
Are you talking about like the new tracer versus the FDG tracer
Yeah,
for
new
SUV?
tracers, BGRT versus FDG.
Yeah, I'm probably going to have to go to my colleagues, nuclear medicine colleagues, and a lot of that, the bottom line is the if we can detect the same level, as I said, SUV has to be 6 or greater for us to be able to detect with the current version of reflection. I'm hoping that there will be enhanced sensitivity along the way. And then the other thing is a noise to signal ratio. And so we can enhance the noise, the signal-to-noise ratio, and much of that can probably be done with software. We actually can potentially enhance that for other tracers that have probably less activity or lower SUV. So that's just, it's very much a noise to signal, a signal to noise. Yeah.
Great. Any other questions?
Thank you.
Okay, thank you, Thank you, Dr. Lei. So we are gonna have a 15 minutes break.